we're not talking at the same time. I'm gonna have to figure that part out later. So what I'm gonna do is I'm gonna give the floor to I'm gonna give it to you, Dr. Botelho, since this is not your first rodeo with us, and I want you to kind of help moderate as we can, moderate the discussion between the three of you. You guys have all the topics. You guys were doing awesome earlier without me, so let's just go for it. Okay,
Sounds
go
good.
for it.
All right. Well, we're improvising here. I'm feeling some echo at my end now, unfortunately. Are you hearing echo at your end?
It's improved.
It's improved. Okay, just testing. I just want to make sure. Actually, I thought we should start off with Adika about because you're experiencing the front lines. You're the youngest of us, and it might be worthwhile having your perspective of what you're seeing happening to the physician pipeline.
Okay. So I'm Erkeda DeRouen, and we were just before we had started the episode discussing what is going on with our younger physicians in terms of what the COVID crisis has brought upon and other things like burnout. And there seems to be a lot of factors. For one, there was a lot of working going on this year, which is totally appropriate in terms of the need for people on the front lines to work a lot. But there are also financial constraints with different organizations and hospital systems that may have caused people to need to get a pay cut or be laid off, or even cause people to wonder if this is what they want to do long term. So some people have decided to go part time or to look into other sectors of medicine in terms of like working for pharmaceutical companies or doing things outside the box in which they may have not necessarily thought of before. So I think that this year has kind of created even more of a crisis in especially primary care where we already had a shortage of doctors, and now it is the gap is even widening more.
So, Avian, would you like to ask her a question, given what she said?
Sure. It's interesting. I do still see patients. I've been seeing patients in the urgent care setting for the past few years, and certainly that's been an adventure since COVID started. But I really do think it would be interesting, Arcadia, if you could speak to how priorities maybe have changed over time. It's so funny. I never think of myself having been out of training that long, but I really have been, especially when I start to look at how the process has evolved over time. So, can you maybe compare what your experience was like to what you're seeing now in terms of new graduates or new graduates from residency or medical school?
Absolutely. I've been having a lot of these discussions recently because I host a podcast called The Prospective Doctor, which looks into hot topics in medicine as well as helps pre-meds and med students kind of navigate the road of entering medical school in their new journey and figuring out where they're going after residency and things like that. And with that, I think from when I graduated, which was from med school about 8 years ago. Time is flying, but it's crazy to me. A lot of things have changed. Like there are a lot of in the medical education realm, there are a lot of extra resources that we didn't have. Like there are Instagram pages that show how to study. Like people have things like Zoom and Slack where they can communicate and move offline, and that is virtual education has actually increased, of course, this year because a lot of, at least in the first and second preclinical years of medical school, they don't necessarily go in person given the situation of COVID. But even further moving from that, I've noticed a lot of my friends in particular are getting what I'm liking to call like the 5 year itch after residency, where they're wondering where they're in more traditional brick and mortar offices or working for hospital organizations that they may wanna dive out into their own into things like DPC, direct primary care,
Right.
or things like working for health departments or looking for other ways to practice medicine different from this traditional administrative based way. So a lot of people are looking for those type of experiences, as well as what they're looking into, what they're calling like side hustles and other ways to monetize their medical degree, which kind of, if you say monetize your medical degree, it can kind of put a sour taste in your mouth. But when you think about it, is utilizing the clinical skills and knowledge and other things that you've gained throughout your experiences and leadership and things like that, because everyone is a leader who's a physician, to help other processes and other organizations.
It's interesting. I think that point that you bring up really mirrors a lot of the discussion around what business model is best. One of the things that we were talking about pre-launch was, how much or how not great of a job medical education still does in terms of training us to understand the business of medicine. And one of the questions that I get in my private consulting business all the time is, how do I choose a business model? How do I run this organization? How do I run my own practice? How do I obtain financing to even start? Where do I start? So, and it's also interesting, she brought up another point that's really common, the guilt, which is a strange word to use, for earning money as a physician. So one of the things that I talk with my clients about often is a mantra of, it is okay for physicians to earn money. It is okay. We certainly invest astronomical amounts of money in our education, and that does not account for the time that we invest in our education that we cannot get back. So I don't think that it is uncommon, but it always catches my attention when people really do honestly feel guilty about earning money from the education that they've taken over the past 10 or 15 years. So I think as we really get into this discussion, one of the things that parallels Dr. DeRowen's point is, how are we teaching minority students, really in everyone, what a business model is and what that's going to look like in 21st century medicine? I do think there are lots of discussions left to be had there. And I also think there's room, lots of room, to improve formal education in medical finance when we're students and when we're trainees. As a matter of fact, I think one of the experiences folks don't take advantage of enough is not just shadowing a physician for the purpose of getting clinical experience, but also having the discussion around, so how do you run this shop? What are your biggest challenges? What are the things that cost you the most? What, if you had a perfect world, would be your solution to those? Those are things that, as we really welcome the next generation of physicians, I think we should pay closer attention to, because frankly, it's a huge barrier. We're talking to folks like myself, who are first physicians and their family, certainly didn't come with the financial backing to, or knowledge really, it's why I went back to school, to do all of those things. So it's really interesting how those things parallel, in my opinion.
I love everything you said about that, because it is true. Like a lot of people don't have the financial literacy to even know how to run their own household or to repay the astronomical amount of student loans that people leave medical school with on average now. And in addition to that, they're expected to learn how to run a practice or how to bring money into there. I know personally in my residency program, they were quite sticklers and really good at teaching us how to code and how to bill, but everyone wasn't taught that in their residency or in medical school. So when they get out and they actually have to have these RVUs and other things that bring people in, and they're not coding appropriately, it really makes a difference. Or if you become a leader, like I'm kind of a few years into my new leadership role, and you're expected to make these decisions that affect your practice with financial things in mind, because it is a business.
Yes.
But if you have to make these decisions, we're trained to treat patients and care for patients, which we should, and that is the most, and that patients should always come first. But a lot of people don't have those skills, and it shouldn't be on them to learn on the fly or on the job. We should have training formalized for that.
I have a question here from Morales, and I thought we could all take a stab at responding to it. But he says, what do you think is the biggest obstacle for those who want to enter and run family practice? And I'd also add pediatric practice to it, especially in underserved areas.
I'm curious for your answer first, Rick, since you have a lot of experience in rural areas.
Well, when I came over to the States in 82 to 85, I ran a rural residency training program, and I wanted to work in rural practice. That's what I did in England. And needless to say, there was a financial crisis at the hospital, and they had a budget cut, 20% across the board, and they had to basically close down the clinic. It was going well. It was a residency training program. It was great. I was enjoying it. But those financial issues, actually, fast forward, are much worse now. And not only that, rural health. I just did a sort of 6-month stint in rural health here, just outside in Bowling Springs, just outside of Charlotte, North Carolina. And it's worse. I mean, the number of people who don't have adequate health insurance, access to services, and there's no game plan. I mean, there's no game plan for primary care. So, and then you add COVID on top of this, and you've got this huge crisis where physicians are deciding, mid to late career, saying, I don't know whether I can keep going. The American Academy of Family Practice is trying to, support physicians to stay in the game. But I want to come back to the financial models. The financial models are broken. I mean, the coding, the volume-based service is a hamster mill for feeding it's just seen as an amplifier effect benefit to hospital systems, and they have no vested interest in doing second order change in primary care, where you need to go back to, that's where I think the DPC practices are good. And just to answer his questions, and I'll let you respond to it. I mean, there are companies out there that will help physicians set up a DPC practice. And I was approached by one, and they said, well, it's going to take you about $80,000 to, get it, to do all the sort of things that you weren't trained to do. Interesting enough, and I'll end with a story, I just had a resident working with me. And I went to the resident and I said, have you thought about DPC? I mean, I can connect you up with a broker, these resources. But, when you're coming out of medical school with a large debt and you're thinking, am I willing to go at risk and maybe go on the hole for 6 to 12 months before I make a living? It's extremely difficult. So, people are underestimating the crisis in primary care in this country, and nobody is talking about it. Over to you two guys. That's my quick response. Reactions or additions, as you please.
Well, I think Dr. DeRouen also, she made another great point to step back just for a second in terms of, we as physicians really are trained to feel. We are physicians because we feel passionate about taking care of people and taking care of their health. And what I think we have to understand really clearly is the fact that medicine and finance are two very different languages. When you're talking to a group of physicians versus a group of financiers or administrators, they are two completely different conversations. And part of the reason that I went back to school was to be able to speak both. And now I serve as a translator between the two. Mm-hmm. And so I think when you're talking about Dr. Botelho, rural health, and I'm certainly familiar with those challenges being here in Texas, I think one of the problems a lot of folks run into is the altruistic, I'm just going to go and land there and throw up my shingle and the people will come. But I do think there's an awful lot of research that still has to go into what are the needs, the old school population health assessment or community needs assessment to figure out what is needed in that community to be sure that if you're going to take this risk, and it is a risk, that you're providing services that are actually needed in that community that will earn you revenue. And I do think that pre-work is a huge part of the issue. However, I also agree that DPC is the way of the future for rural health. I don't know that we as physicians can influence the monster that is health insurance in the United States, but I do think that we are 100% capable of building practices and access models that give our patients a chance to get to us. Mm-hmm. I also think it can be done where you are able to earn money. Again, that altruism sometimes can be blinding in terms of how are you going to survive if your practice doesn't turn over an income in the first 12 to 18 months. So I think that there are steps to be taken. I don't think you can take them a few months before you open the practice, but I do think that they can be taken and that ultimately you could be successful, but it needs to be very strategic.
Mm-hmm. Yeah.
I think that you guys probably summarized it the best, since I don't have much experience with running a practice. But I will say from my experience and the experience of a lot of my colleagues who have come out around the same time that I have, I think a lot of people do tend, at least in my generation, to avoid things like DPC and private practice because they're being discouraged. So a lot of the training focuses on academia, where they're like, okay, this is all we know, and those are our trainers because they stayed in academia. So this is the next step. You stay here, or you work for a hospital organization, or you go to a large corporation like a Kaiser or something like that, where you know what your salary is going to be and you know your requirements and how many patients you're going to have on your panel, and you do that for 30 years. But in reality, that's not what the future is, and I think a lot of people are starting to see that, and there are those fears like was mentioned about we come out with astronomical amounts of debt, and to take that on, and like you said, sometimes it takes 6 months to a year to have a functioning practice and to build up that panel and things like that. It may deter people for a little while. They'll say, oh, I'll work for this place for 7 or 10 years so I can pay off my loans first and then do what I want. Or, oh, I will need to work for like the National Loan Repayment Services so I can work on that and then live my life. So it's always a plan to do something that they don't want to do and then move on. So I think there needs to be more training on what resources are available to help people do what they actually want to do when they want to do it, so that they can like take a leap of faith and step out and pursue that and help patients while they're at it.
Yeah, I'd just like to return to the point about the gap between the culture of business and medicine, because I think that's a huge problem, and it's seen in hospital systems too, because hospital systems tend to be more business run than clinically run. Now, that's not true with all healthcare systems. Think something like Kaiser Permanente, at least it has much more of an integrated business clinical model. But there's a lot of legacy systems out there where they're very much in the old system, and they're not invested to make the needed transformation in primary care, regrettably, because it's not in their short-term financial interest to do so, because they're going to have to do a lot of work to make that transformation. Having said that, there are some exceptions, and there's one person that I'd like to highlight. It's a book called Lead True, and unfortunately, I think I can't remember the name of the author, but he was a CEO of a hospital system, and he did exactly what Dr. Tisdale was talking about, which was he worked from a community up. He did community-based assessments and worked up and took that perspective in. And to be quite honest, this is a guy, I'll have to see if I can find it once I stop speaking so I can get back to his name. But he was so visionary because he thought about everything from an ecological perspective, from the community all the way up. So it wasn't hospital driven. It was basically driven from with a community perspective up. And that is by far the biggest fault of the American healthcare system, is that it's not community-based, looking at the needs of people and designing systems around the needs of people. I'll let you respond and I'll find his name, okay?
Sure. I think that's a great point. And I saw a question in the comments from Rollis about what could be taken out of our education or replaced or revised. And it's interesting because I think that, as Dr. DeRouen was saying, the debt and the pressure that we graduate with, but I think that starting medical school is the time to have that conversation. For example, do you want to be a primary care physician? Yes. Well, that yes isn't very valuable without a how. So I think that's the time when we start to have the conversation about, okay, how would you like to practice? Do you want a multi-provider practice? Do you want a solo practice? Are you going to be in a metro area or rural? And I think the conversation starts there. However, I think also the education and personal finance starts there. There would be far less pressure if we were more educated about how to manage our loans, how to manage our personal finances, what these interest rates mean, also what contracts mean when we sign them. As again, a private consultant, I am just downright shocked by the number of physicians who have literally signed their lives away and did not realize what they were signing, by the number of people who sign on to a long-term situation that could affect their decision to go into private practice later with non-competes and other terms and elements that are included in a lot of contracts. So I think that's the time to start talking about personal finance, because the truth is a lot of specialty choices and residency choices are made based on how you want to practice. If this is the specialty you want to be in, here's what the options are and what the trajectory looks like versus another specialty, for example. And then I think in residency, that's the time to really learn from business professionals and physicians already in the industry what it is you need to know to be able to actually do it. I don't think anything needs to be removed from our education. It's rigorous for a reason, but I do think there is plenty of room to inject education about personal finance and business in medicine.
I have nothing to add to that. I completely agree that there needs to be a sort of early introduction and for it to be longitudinal. And even probably before medical school, for maybe the people who are pre-meds, there needs to be some kind of, they have things on the MCAT that they need to study for, prerequisite courses. Perhaps they need to have a prerequisite course on the healthcare ecosystem and economics or something like that. In medical management, but I think that it needs to start early and not just end after one semester or one course, but keep building on.
Agreed.
There's another avenue that's been, I don't know whether you're familiar with it, but there's something called City Block. Have you heard of City Block out of New York City? And interesting enough, they tried to set up 3 clinics here in Charlotte. And it was all banking on capitated Medicaid contracts. And so they opened shop, and I actually went to look one of them because I thought, that's the type of environment I want to work in, because you have, that's what I call advanced direct primary care, where you have a team, and it really is based upon looking at the needs of the people. And it's a venture capitalist group backed by venture capitalists. Which is sort of like an oxymoron. You think, how are they doing this and that? We need some new models. And I thought it was so cool. So I went and I got interviewed for it, only discovered that the whole thing collapsed because the Medicare contracts didn't get approved in North Carolina. So, even if you come up with great ideas, if the system isn't going to support it, that's the sort of innovation that's needed. We need to completely develop new integrated business clinical models that are designed to serve the needs of people, which is why we went into medicine in the first place, and the system is working against us. So I'm not, it's going to be fascinating to see what happens after the election and the outcome of the election, because whatever happens is going to have a profound influence. Unfortunately, I think most of this is going to come from the states, because we can't rely on federal leadership at the moment to be able to deal with it. All you can say when you combine COVID with this crisis, crises are the best things for innovation. They shake the system to the core. And it might even wake up some sleeping giants of the hospital systems to say, well, maybe we should turn course. We've got a really we've been thinking about value-based care for the last how many years, and it really isn't value-based care. It's just check boxes that you have to fill, and it has nothing to do with the real care that you're providing to a patient. So we've got a work cut out for us, Any source of inspiration? Can you give us any sources of inspiration?
I agree with that. And what's really interesting is I think that we're in a fantastic time because there is a lot going on that is unknown and uncertain. And being in healthcare, we know that healthcare, personally, I think healthcare is a right, but we know there's a lot of drama with that. But I think that given the age that we're in with all of the technology that is around and the technological advances, we have this prime time where a lot of people are focused on health and how to interact and how to affect it. So I participated in a speaker session about 2 weeks ago for MIT focusing on hacking racism in medicine. And they have a lot of other kind of sister programs like Hacking Medical System, Hacking Healthcare. And this weekend, we're actually going to have a hackathon where they look at the issues and health disparities and research projects and even like primary care and access and how people can improve individual wellness and health. And the students are going to come together and come up with ways in which there can be like actual solutions and compete in a way in their like hackathon, like techie way. But I think even if the students don't necessarily have their project or idea move forward, there will be a lot of information and innovation and inspiration for people to go in the future and work on those things because it's kind of being discussed and talked about, and it hadn't necessarily been talked about on a large platform before.
Okay, Ross wants to cut in very short, but I just want to say one thing, and that is that the MIT hack racism thing you're talking, or is it a different hack?
Yes, the hack racism one.
It's interesting because I volunteered to be a mentor for that, so it'll be interesting because
I'll see you this weekend.
Anyway,
but it was a really good experience, and for those who may join this weekend, that's wonderful. But I think that they should go and look on their website and look at the discussions that were done 2 weeks ago, because it talked about a lot of the things like Dr. Tisdale was bringing up about the financial issues and the financial literacy that needs to be brought up, or the public health issues and why in rural areas certain things aren't being done, or why in certain communities like the African American communities, why they're dying twice as more likely than other people from COVID and things like that. So the discussions have been sparked. So this weekend will be exciting to see what solutions they come up with.
Are you going as a participant or as a mentor to the group?
I'm gonna be a speaker and
okay, good.
Judge.
A judge? Oh, a judge! I didn't realize I was a judge.
We'll work it out.
No, we'll have to connect. We'll have to connect.
Yes, we'll talk.
And actually, thank you for reminding me, because I'm supposed to go to the training at 6:00 this evening. So I'll let Wallace chime in now if he wants to chime in.
Yeah, so bear with me for just a couple of moments. I've just been enjoying the conversation. You guys have been awesome, and thank you for dealing with things in stride. And it's been a great conversation so far. One of the inspirations for getting all of you together today, there's two things I want us to kind of talk about for the rest of our discussion, or as much as we can. One is many have felt like that this COVID has kind of uncovered some things that were already there, or it may have amplified some things that were already there, and some feel it may have even caused some of the things. But I want to get y'all's perspective on this as far as the injustices and inequities between certain demographics receiving much worse results from COVID. I want us to uncover what are some things that we can do to help more, even for one example, more minority physicians that look like the patients that they are treating, because they found, and maybe you guys can speak to this, they found this in studies that a lot of times there's better outcomes when they're being served by those who at least look like them, or they feel a connection with, because there's more of a mutual understanding. So what are some ways we can get more physicians that are of varied backgrounds practicing and working on these, working with these patients that are perhaps, whether it's COVID or something else, but working with them to better mental health? That was one of the big things I want us to kind of just touch on. How can we? What are some of those obstacles, and how can we remove them? So I'm gonna be quiet and let you guys take it from here.
I'll take the tip.
Now it seems like there is an echo again. Do you guys hear it?
Yeah.
We'll let him correct the sound. Okay, it sounds as though he's fixed it. Okay.
Okay, that sounds like it's fixed. So I guess I'll go first. I think that that's a really great question as to how we can address the diversity in the medical workforce, because I think it's a very important issue, especially in like African American populations, there's a lot of distrust historically from all of the things that have happened over the past 400 years in terms of like experimentation, whether or not it was in slavery or the eugenics projects of the 70s, or even now in certain issues. So there is some valid mistrust. And on top of that, Black doctors make up 5% of the population of physicians. So 95% of them are not Black. So I think that we need to have everyone on board to help patients feel comfortable and to feel like they can connect with their doctor and their doctor has their best interest at heart. And I think that a lot of physicians are altruistic, and that's the reason that they went into medicine, to help patients. But I also, being real, bias, like everyone has biases. So we need to address them and let people know what's going on and let people know like why there may be some distrust and how we can kind of build that bridge and that bond to help everyone feel better, as well as like minority physicians. Everyone needs to be in the room where decisions are being made. So if there is a group of physicians making decisions about certain patient initiatives or different hospital systems, you need to know about your population that's out there and to keep them in mind. So it would be pertinent to have someone from different backgrounds. There are women, men from different backgrounds. I think that Black males make up about 2% of doctors, period, and Black women make up 4% of the 5%. So we need to increase those numbers. And the way we can do that is by encouraging students to pursue these and not be discouraged if they don't get accepted the first time, or figuring out how to mentor these students and let them know the things that they need to do to make their applications better the first time, giving them ways to study for these standardized tests where we know that some minority students don't do as well on standardized tests, and it's not because they aren't brilliant people, because they are, but it may be because of the school systems that they've been through haven't prepared them to study for standardized tests as other school systems have. So we have to think about and acknowledge those differences and those disparities and figure out how we can encourage there to be more diverse people in the workforce to get into school and to go and serve those patients, but also utilize the doctors that we have and make them all treat our patients appropriately.
Sure. I think, three things come to mind when we're talking about answers to this question. And the first is really understanding the scale of physicians in the United States. There are 350 million people in this country. Physicians make up about, well, at any given time, less than 1 million of us are here in the United States. And even fewer than that number, somewhere around 800,000 to 900,000 of us are actively practicing. So we talk about strength in numbers in lots of different settings, but our numbers are always going to be on that scale very, very small. We make up less than 1% of the population. And I think COVID really uncovered that, oh, wow, there really aren't that many physicians here. And I think people sort of discovered that on the fly, and it's a very important point. But to that point, representation is extremely important. And I want to explain what I mean by that. I see patients now in 2020 who have never seen a Black physician before. They will tell me, oh my gosh, this was wonderful. My son has never seen a Black physician. And it absolutely hits me like a Mack truck that we can get to 2020, and these are teenagers who have never seen a physician who looks like them. So representation in the communities where people who look like us live is extraordinarily important. I've had kids email me, reach out to me on social media. Gosh, I know I saw you a year ago, but now I'm thinking about going into medicine. And that is really where change happens. On the other end of that, though, Dr. Botelho pointed out an issue that gets back to the how with Medicare and all of the fragmented issues that are in existence right now with healthcare. Representation for physicians at the federal level is also extraordinarily important. COVID, I think, really uncovered the fact that we have so many agencies that we pay dues to every year that have done a good job of regulating physicians, but when it really comes down to it, don't do a good job, in my opinion, of representing physicians and our needs at the federal level. I don't think for any reason we should be paying thousands of dollars to our specialty specific organizations, and yet practices are closing by the dozen every week. So I do think that representation from a cultural perspective and representation from a professional perspective are seriously important. The last point is mentorship. It really surprises me how little people will utilize African American physicians as mentors. Even when I've offered myself up for free sometimes, it really can be challenging to get people locked into, let's have this discussion, let's be consistent, let's go over things that are really going to make a difference. But I do think that mentorship early on, exactly like Dr. DeRouen said earlier, is extremely important in terms of these are things you need to be thinking about now. So many times we come into contact with folks who have great ideas or really have the right plan, the timing is just a little off. So I do think that COVID has shown us there are scale issues, there are representation issues on both ends, and also a huge, huge need for mentorship in the African American community.
Just to move this in a sort of a slightly different track, I just want to share a story that when I was last on this show, I spoke and I asked the group of human resource people about a phrase which I've never liked, which is social justice warrior. And the reason why I don't like it is because it's a war metaphor. And I said, I've got another phrase and I want to give you an alternative and I want to get your reaction to it. And I said, what do you think about equity peacemaker? Well, the group just loved it. I mean, it was like, and one woman suggested to me, hey, why don't you do a tie-dye t-shirt with a peace sign and put equity across the top and then put peacemaker below it. And then on top of it, the crowning glory was a physician actually sent me a copy. He actually made, he made a book cover for me with the title and whatever, and he sent it to me. And, you know, when I was on that call, I shared a blog post, which I'll share with you, which is actually called Hack the Isms of Inequities and Injustices of Fake Patriotism. Because I know we're not supposed to talk politics here, but health is political and you can't get away from it. You can't separate it from business. You can't separate it from it. It is a political process. But I would posit that equity is a humanitarian cause. It's a humanitarian cause. It's not a political cause, but partisan politics makes it incredibly polarized and divisive. And that's why healthcare is not a human right in this country. I could talk at length of this, but I'll keep it short. I'll let you react to it. And I
love it.
I'll put the blog post in, and you can share it with the students that you're meeting at MIT if you're interested. Because it's a long thought piece. This is not something, this requires slow reading. It requires deflect. It's not a quick blog read. I'll give you that advance on it. But
I appreciate you saying that because there have been a lot of talks and there's a lot of taboo about politics and medicine and professionalism and those things, but health is life. Health is a social determinant of health. You may have seen me looking back because I was like, really excited that you mentioned that, and it actually was on my desk, but I'm reading this book called The Political Determinants of Health because that is what it is. And it's very important. Like, it all goes together in order for people to give to the economy and work, and we're seeing it now play out live in 2020. If you're not healthy, you can't work, you can't help the economy move, you can't send your children to school, you can't do all of these things that will make the country run, and it all ties to health. So why don't we create a healthy nation?
Yeah, exactly. Well, you know, to me, I really like that book actually, you know, I even go a step up, saying we need to talk about the ethics of health, because it's really an ethical issue. It's not, once you get into politics, I would posit that we should be able to treat equity as though it were a non-profit cause, which means that you do as all non-profits do. What is fair to you? What is fair to me? What's fair to everyone? And we need to have a lot more discussions about what fairness is and what unfairness is. And it's only through storytelling that you can begin to move people. But unless you get the stories coming together and people saying, you know, equity is a good thing for everyone. And if you can get people on that bandwagon, then you can start rolling back some of the isms that were, you know, that have been revealed by COVID.
Mm-hmm.
So
I really think, I think that phrase is brilliant. I'd like to really, when you said that, I thought about looking at the heart rates of physicians when you call them social justice warriors versus looking at our heart rates when you call us equity peacemakers. I'm not sure any of us go into medicine to be at war.
exactly.
You know what I mean?
Exactly.
We go into medicine to bring all things equal to every patient, every time, every encounter. And we certainly want to make things peaceful for our patients, our families, and our communities. We also have to make things peaceful for us.
Exactly.
And I think that the frustration many of us feel many a day in this industry is brought on by the fact that we are being made into soldiers, into warriors for many different
exactly.
things.
Exactly.
And I don't think that that's appropriate. And I do think also that we contribute to the crisis, and it is a crisis of mental health that is still going on in the physician community today, because we get up every day and we feel like we're battling.
Exactly.
And that really is not why we came here. It's not our duty, and it's not our strength to be soldiers. We are people who, I'm a pediatrician, for goodness sake. So, you know, my days are supposed to be filled with things that bring people joy. So I think that I'm a huge language person, and I think that makes a huge difference.
Yeah, well, I'm going to champion. I'm going to develop some learning. I've already developed the materials for it. I just need to find audiences. The thing is, I'm just a mere minion of a thought leader, and I have very little influence. So I have to get to influencers within organizations to be able to put this learning program up. So that's the COVID crisis is accelerated my longstanding interest in equity, and has allowed me to be far more creative than I'd ever have been had it not been for COVID. So that's my silver lining. And I can see Rollis is may want to chime in, because we're coming up to the hour, I think. So I don't know if you want to, we're up till 4, right? I think.
Yeah, so I'll just chime in for a second. I wanted to ask you as we wrap up here, what's the one book that you have read that you would reread if you had the opportunity? So I wanted each of you to briefly mention that, and then after you finish that, what's the best way for folks to continue the conversation if they wanted to reach either of you individually? Should it be through your LinkedIn profile or some other means? I want to make sure we get that in before the end of our discussion, but feel free and go from here.
The book I would recommend that I would reread is Never Split the Difference by Chris Voss. He's a former FBI negotiator and just has pure gold on every page about how to understand people, read body language, negotiate from a practical standpoint, and also insert that knowledge into every conversation and interaction that you have. I really liked it. I'm sorry, what was the other question?
How they can contact you.
LinkedIn. You may find me in your inbox, so feel free to come into mine.
I guess I can go next. I have started that book. I haven't finished it yet. It is really good. For me, I would say one of my favorite authors is Jodi Picoult. And given the topic and the situation that we're talking about, she had a good book called Small Great Things. And it talks about racism in medicine. It talks about the administration portion of medicine and what kind of decisions that supervisors should take to protect the well-being of their employees. It also hits on the justice system and what is fair and what is not fair. So if anybody could read that book, I think that is something that's very relevant to today's world, especially in the healthcare realm. And you can reach me on LinkedIn as Erkeda DeRouen, ErkedaDeRouen, or on Instagram as Doctor spelled out DoctorD as in the letter Graham, GRAM. And I have a weekly podcast that you can listen to that on Spotify, Apple Podcasts, or Google Play called The Perspective Doctor.
Do you mind putting those in the chat box?
Absolutely.
That would be great. That would be great. I was really, I'm glad you guys went first because it gave me some time to think, which book shall I pick? I want to pick one that I actually was given over 10 years ago, and I go back to it. It's almost like a Bible, in the sense that it's a book that many people haven't heard about. It's called Character, Strengths, and Virtues. And it so happens I have it right up my side here, and it's this book here, okay? And the reason why it's like it's like the opposite of the DMS 5 or 6. I don't know what version there is now. And it's the opposite. It's actually about virtues and character strengths. And there's a website that you can go and do an assessment of your virtues and character strengths. It's called Values in Action. And it's really everything we should be cultivating virtues. If we're going to go to equity, it means across the board, we have to think about how we cultivate virtues. Because if we cultivate virtues, a lot of all this stuff that we're living through at the moment will melt into the background and be marginalized. So unless we can raise up the good, we can't marginalize what we don't like, what's happening at the moment. So it's not a book that I look at very often. It just, I go and look at it now and again because it's dense reading, but it's a great book. So do you want to close this out then, Rollis? Or are we...
I want to thank you guys. This was really an enlightening discussion. Hopefully, we'll have you back on. Hopefully, you'll be willing to come back, even though we had our audio issues. But I can tell by the comments, folks really enjoyed it today, and I did share the links that you gave. We're going to actually, folks, whenever the doctors leave, we're going to go ahead and offer a couple of books out that they recommended today. And we'll do that since I promised a book, but I don't want to hold them up because of their time, because we started a little bit late. I would definitely want to thank you, Dr. DeRouen, Dr. Botelho, Dr. Tisdale. It's just been an amazing discussion. I appreciate everything you're doing for healthcare and giving back like today. Just things like this really helps, I think, to get the word out. So we appreciate what you're doing. Thank you for being on the show today. Awesome. Okay. We're going to have you back. Please come back one day. Okay. Have a great rest of the day. So folks, we are going to give away a couple of books, and sorry we had some little issues at the beginning. Thanks for hanging there with us. What I'll do at this point is, let me just change my screen here. Oh, wow. Okay. Okay. So here's the autos back again. Sorry about that. Wow. So all that stuff I just said, you didn't know. Okay. So what we're going to do is we're going to give away a couple of books for those of you who want to win a book. Glad you're still here. Thank you for being here. If you have any questions, feel free to put your questions in the comments, even if you're watching the replay, because what we're going to do is we're going to actually make sure the physicians see the questions that you ask. So feel free and put those questions. We'll get them answered. So let's go for we're going to give away one of these 3 books that Joe has just listed. They were all recommended today by our doctors. The book recommended by Dr. Tisdale, Never Split the Difference, by Chris Voss, by Dr. DeRouen, Small Great Things, and Dr. Botelho, Character, Strength, and Virtues. So we're going to give away any one of those 3 books. You're going to have a choice to win either one of those 3 just by completing this next challenge. Thank you for your comment too, Patty, that she says, I found the points about the lack of business education being included in medicine very interesting. So thank you for that. So the word of the day, and you just type in each word is going to be, each letter is going to be represented in each comment, right? So separate it out, each letter for each comment. The first one to finish the word will actually win a copy of the book. The word that we're going to use today is health. Health. The first one to enter that in will win a copy of the book. And that's what we'll finish with today. Really appreciate you guys being on today. And as we do that, I'll ask a question too. Out of all the things that you heard today, what point resonated with you the most? I know Patty mentioned, she talked about the business aspect. Never really thought about that before. Is there any other points today that resonated with you that perhaps you didn't think about before, or that you thought was really a great point that we should consider going forward? And do you like this type of content? We love to continue to see your comments on the type of content we're putting out there. We want to make sure that this show's for you, right? It's not for us, it's for you and for all of us to connect. So let us know what's working for you. All right, so let me just hit the refresh button here and see how we're doing and see who won the book. Okay. And the word for the day for the book is health. Okay. And I'll ask you one little question for those who aren't doing the actual challenge. I'll ask you this question. Would you rather, this is interesting, would you rather see everything in slow motion or see everything move at double speed? Which one of those would you choose? That's kind of a different kind of question right now in the middle of COVID. Would you rather see it in slow motion or everything at double speed? Love to hear your thoughts on that. And let's see. Okay. Well, you deserve it. Looks like our winner is actually Joe, huh? Let's make it official. Awesome. Well, you'll be able to pick which one you want, Joe. Thank you. Thank you for being in. Thank you, everyone, for watching today. Really appreciate all of you. We'll be back tomorrow for our Fun and Games Friday. Sorry we started a little bit late today, but come back and see us again. We appreciate all of you watching. Okay.